मैं कंप्यूटर पे हूँ, यहाँ पे आपकी डिजिटल
सर
लाइब्रेरी में हूँ मैं।
F5, ठीक है सर, F5 कर दें, स्क्रीन फुल हो जाएगी सर।
जी जी, मैं स्क्रीन शेयर कर रहा
हो गई सर,
हूँ।
हो गई
ओके,
सर।
ठीक
ओके
है,
सर, ओके।
थैंक यू। Hello, Assalamu alaikum everyone. I am Dr. Naman. I am Assistant Professor Cardiology, Consultant, Interventional Cardiologist. I am so sorry for being late. I am here in the digital library. I've been working since last 10:30 and I am unable to connect the lecture. Now we are starting our lecture on the stable ischemic heart disease. So if we talk about the ischemic heart disease, uh, the most common cardiomyopathy in our society in all over the world is is the ischemic heart disease, and we have classified ischemic heart disease into the stable and the unstable. The unstable one is a part of acute coronary syndrome that must be discussed or will be discussed. And today's topic is stable ischemic heart disease. Stable ischemic heart disease, it means there is a coronary artery disease, there is a plaque in the coronary artery disease, which how we will manage, how we will continue, that we will be discussing in today's topic. Okay. So if we start with the patient profiling, we involve the local heart team. In heart team, we have a surgeon, interventional cardiologist, and cardiac anesthesiologist. And we have a different scoring system on this that we will be discussing on the later on this presentation. Okay, suppose we have a case. Is a 66-year-old man with a history of hypertension, type 2 diabetes for 20 years, and mixed hyperlipidemias, smoker and quit smoking for 20 years. He has been smoking for 30 years and treated with the bisoprolol, valsartan, rosuvastatin, and metformin, and can climb up to the fourth floor, has no any symptoms. So question number one is what is his diagnosis? What test would you order for him and why? And what is the most optimal therapy method would be received? Okay, so in general principles, uh, obstructive coronary artery disease is defined as a more than 50% luminal stenosis of any epicardial coronary artery disease. While we intervene obstructive coronary artery disease once anginal symptoms or stenosis of more than 70%. Obstruction by atheromatous plaque. Basically, what happens that uh, atheromatous plaque, that process starts early in the life, and at times it's a rapid, at times it's a slow. So people with the risk factors like smoking, diabetes, or other risk factors, this atherosclerosis process become rapid, and this disease manifests with complaint of stable angina or unstable angina or myocardial infarction or heart failure. So basically, this presentation depend upon the severity of disease and uh, percentage of obstruction of epicardial coronary artery disease. Okay, so coronary artery disease, basically stable angina, that's today's topic: SES and congestive heart failure, sudden cardiac death, and the silent ischemia. These are the topics. These are the common presentations with these atherosclerosis coronary artery disease. There is a term chronic stable angina that mimics the stable angina, that's the stable exertional angina or the stable ischemic heart disease, ischemic cardiomyopathy disease, EF less than 45% due to coronary artery disease or congestive heart failure, may be present, may not. So this diagram shows the stages of atherosclerotic plaque progression. In the first, my cursor is showing is a lumen of coronary artery. This is uh, a wall of the coronary vessel, and there is a mild plaque. And this plaque progresses by time, and time comes when this plaque become progressive and obstruct the coronary artery disease. Once it's stable, there is no chance for the aggregation of platelets and activation of the coagulation factors. Once it become stable, once it become unstable, suppose this plaque is covered by the endothelium. uh, our endothelium is resistant to the activation of the platelets. Once this endothelium is disrupted, subendothelial matrix is exposed, and the subendothelial matrix, once exposed, it can lead to the activation of the platelets and the coagulation factors, which lead to the thrombus formation. So this plaque is an unstable plaque, and this is part of acute coronary syndrome. The acute coronary syndrome includes unstable angina, non-STMI, and ST elevation MI. But once this plaque is stable, if this is stable, there's no chance of the activation of the coagulation factors and the platelets. But depend upon the severity and the size of this plaque. If this plaque is obstructive, suppose is the 70% or the more, then can lead to the symptoms of angina. That's called stable angina. So definition of stable angina is angina that can be predicted. Okay, the patients complains that if I walk for 20 minutes, I become fatigued and develop chest pain and the chest heaviness, which radiates to the jaw or the left arm. And before 20 minutes, there are no symptoms. So basically, physiology or pathophysiology behind this is the demand and supply. If demand is high, demand, a patient, if it starts walking, his blood pressure and heart rate are increased. That's normal physiology. During walking, heart rate and blood pressures are increased. If increased in heart rate and blood pressure, there must be an increase in blood supply. As we have an obstructive plaque in the coronary artery disease, there is no required blood supply to the respective myocardium, which leads to the ischemic symptoms. If this patient stops walking and get rest, then heart rate comes down, blood pressure comes down, and symptoms alleviated, and symptoms become improved. And at times, these symptoms improve with the sublingual nitrates, which lead to the coronary artery dilatation and decrease in blood pressure. Okay, so this is basic pathophysiology. So stable ischemic heart disease, I'm sure the term is clear. When the underlying coronary artery plaque is covered with the endothelium, we will be label it as a stable plaque or the stable ischemic heart disease. Once this plaque is disrupted, then it become unstable, and it will be treated as a SES, acute coronary syndrome. Okay, so how we will diagnose the stable ischemic heart disease? Basically, patient came with a chest pain, would depend upon the severity and location, severity, and the duration of the pain, radiation, associated symptom, provocative factors, and the elevating factors. So what do adjective often used to describe the anginal pain? Often squeezing, grip-like, or suffocating, heaviness on the central chest, dyspnea, epigastric, or the nausea. Rarely sharp or stabbing. And special characteristics not vary with the position or the respiration. This is very important. And the classic Levin sign by placing a clenched fist over the pericardium to describe the pain. And less than 1 minute other are the few 20 minutes stable angina, more than 20 minutes in unstable angina. So these are the special characteristics that we call typical cardiac pain. Okay, so typical angina is a substernal chest discomfort with a characteristic quality and the duration that is provoked by the exertion or the emotional stress and relieved by the rest or the nitroglycerin. These three features are called typical angina. This can be atypical or probable angina. If a patient meets any two of above criteria, then we call it is the atypical presentation, or make treated or maybe labeled as a probable angina. And the non-cardiac meet one or the none of the above characteristics. Okay. So what are the differentials of chest pain? चेस्ट पेन के डिफरेंशियल्स क्या होते हैं? अगर कोई चेस्ट पेन के साथ आता है तो हम हार्ट के अलावा क्या सोचते हैं? व्हाट वी थिंक अबाउट अदर देन द हार्ट? It can be a non-ischemic cardiovascular, that's the aortic dissection can present with the chest pain. Pericarditis can present with the chest pain, and the pulmonary differential or the pulmonary embolism can present with the chest pain, pneumothorax, pneumonia or the pleuritis, and gastrointestinal, esophageal, esophagitis, spasm, reflux, or the biliary colic can present with the chest pain. Okay, chest wall, costochondritis, and rib fracture or arthritis, herpes zoster can present with the chest pain. We can clearly differentiate these differentials from the coronary artery disease. As I have already told you, the typical angina symptom is the central chest pain, which radiate to the jaw or the left arm, aggravated by the exertion, relieved by the rest or the sublingual nitrates. Okay. So if we classify the angina, suppose if a patient comes and the complaints that he has a chest pain after walking a 1 kilometer, if a patient comes to you, he feels chest pain at the 4th floor, and suppose third patient comes to you, the chest pain during the routine household activities, combing the hairs, taking the shower, or changing the clothes. So we can classify the angina on these basis. There is a CCS class. Class 1 in the angina with the strenuous, rapid, or the prolonged exertion. This is a mild angina. Class 2 is a slight limitation of the ordinary activities such as the walking or the climbing stairs rapidly, walking or the standing after the meal in the cold and the wind and under emotional stress. Class 3 is a marked limitation of the ordinary physical activity, walking 1 to 2 blocks on the level and the climbing more than one flight of stairs under normal condition. Or the class 4, inability to carry out any physical activity without discomfort. Angina may present at the rest. So CCS 4, class 4 is a worst angina. So unstable angina basically is not our topic, and this is part of acute coronary syndrome that must be discussed separately, but I am here. There must be students differentiate between the stable and unstable angina. What is difference between stable and the unstable angina? The stable angina is angina that's predicted, and it's a chronic condition. The patient complains from the months and the months, and used to complain that once I walk with the 1 to 2 kilometer, I feel pain. And this complaint is a chronic condition, while unstable angina is an acute condition. So we have a three definitions of unstable angina. The angina at rest is unstable angina. Angina occurring at the rest and usually prolonged more than 20 minutes, occurring within the 1 week of the presentation. Okay, and the stable angina will be the prolonged duration, and within a week, and the angina is the rest is the unstable angina. And the second definition of unstable angina is a new onset angina. So it's developed first time in the life. The angina at least CCS class 3 severity, with onset within the 2 months of initial presentation. Or worsening angina. The patient initially used to say that I feel chest pain when I walk upstairs up to the 3rd floor or the 4th floor. Now this chest pain I feel at the 1st floor or the ground floor or the simple walking, same pain, but I'm feeling earlier when initially I used to walk up to the 3rd floor, I feel the chest heaviness. Now at 1st floor, I have a chest heaviness. This is a worsening angina or increasing angina. Okay. So unstable angina, basically we have a 3 definition: rest angina or new onset angina and the worsening angina. So this comes in the definition of the unstable angina. So clinical characteristics associated with the high likelihood of the severe ischemic heart disease, unstable angina, or the MI. So these are the poor outcomes, or the disease will be very severe, the multivessel disease or the severe obstructive coronary artery disease. So a chest pain can lead to the pulmonary edema. It means there is something wrong. Patient is in danger. Patient needs high attention, need to be admitted at the coronary care unit and needs early intervention. Chest pain associated with the lightheadedness, syncope, or hypotension, again, patient is in danger. Exertional syncope, again, patient is in danger. Or an exercise-induced gallop, that's the sound change. Normally, we have a S1, S2. If a patient starts developing S3, then there is something wrong. Patient is going into the heart failure. So these are the clinical characteristics for the severe ischemic heart disease. Okay, this chart is very important for you. Plaque disruption or the erosion. Plaque disruption, plaque is present almost in every person, but in the small quantity. Once this plaque is disrupted, underlying endothelium is disrupted, underlying subendothelial matrix is exposed. What it lead to? It lead to the platelet activation and coagulation factor activation. Initially, plaque was not obstructive, but this disruption of endothelium can lead to the thrombus formation. Now, this thrombus will obstruct the coronary artery disease, will depend upon the severity and the size of thrombus. If thrombus completely occlude the coronary artery disease, can lead to the acute ST elevation MI, depend upon the territory of. If it is a left anterior descending, it lead to the anterior wall MI. If it is a circumflex or right coronary artery, it lead to the inferior wall MI or lateral wall MI. So plaque disruption or erosion, which lead to the thrombus formation with or without embolization. Then acute cardiac ischemia, which is divided into non-STEMI and STEMI. And markers will not be, if markers is not elevated, then we will label it unstable angina. If markers are elevated, we will call it non-STMI. So in non-STMI, we may have ECG normal or ST segment depression. If this is the worst condition and markers are elevated, artery is completely occluded, it can lead to the ST segment elevation. And this is all part of acute coronary syndrome. So acute coronary syndrome is the ST elevation and the non-ST elevation, myocardial infarction, and which can lead to the further, if not treated, Q-wave MI. So these are the troponin markers. These are the cardiac markers that we use to diagnose the coronary artery disease, obstructive coronary artery disease. After ischemia, there is a cell death. Cell death lead to the release of the intracellular materials and intracellular enzymes. The commonly we use for diagnosis is the troponin. Commonly we use troponins, and other markers can be used. More specific for coronary heart disease is the troponin I. Other markers are CKMB, myoglobin, CK can be used, but commonly used is a troponin, high sensitivity troponin. So risk factors, I have already told you that atherosclerosis is a process which can be speed up, can plaque grow rapidly if these risk factors are present in a patient. So in a patient who is a diabetic and a smoker, his lipids are not controlled, he's a poor blood pressure control, and he's obese and physically inactive, and he has a family history of ischemic heart disease, he is a very, very high risk for premature coronary artery disease. So a family history of the premature ischemic heart disease is defined as is a criteria onset father, brother, or the son less than 55 years, or the mother, sister, daughter less than 65 years is called as a premature coronary disease. As I've already told you that atherosclerosis plaque can be speed up by these risk factors. So atherosclerosis process starts in every person, but process is very slow if patient is a healthy lifestyle, has a no risk factor. So it can manifest in the 70s or the 80s or may not present throughout the life. If patient has a risk factor like diabetes, smoker, dyslipidemia, hypertension, then this process become rapid and disease benefit early in the age in the 40s, 50s or the 60s, and we treat accordingly. So if we start for the condition provoking or the exacerbating ischemic ischemia or the heart failure. So high risk, intermediate risk, and the low risk, we have divided into the three on the basis of the clinical in the history and the characteristic of the chest pain and the clinical finding, ECG finding, and the cardiac marker. If a patient has an accelerating symptoms, accelerating chest pain for the more than 48 hours, and the characteristic of pain is more than 20 minutes, and he is in the pulmonary edema or the new or worsening MR or the new or worsening murmur, he is hypotensive or bradycardic, and ECG shows the ST segment changes, there's a 0.5 millimeter at least changes, and his cardiac markers are the rest, he will be level as a definitive coronary disease, and he is a very high risk. And we work up. If a patient comes with a chest pain, we ask for the CBC to rule out the anemia, and fasting glucose and the lipid profile, TSH and the pro-BNP, troponin T levels. ECG we perform to see the ST depression, ST elevation of the normal ECG, and echocardiography. In echocardiography, we see the LV function, RV function, and the heart valves and pericardium definitely, and we see the wall motion abnormality. Wall motion abnormality, if artery is involved, then suppose left anterior descending supplies the anterior wall, and right coronary artery RCA supplies the inferior wall. If a patient has a plaque in the left anterior descending, and echo we will found the anterior wall will be hypokinetic or akinetic, rest wall will be the normal. If a patient comes with the now we start with the optimal medical treatment. If we ask them to have a stress test, if stress risk result of a stress test is a high risk, we advise them for the coronary angiogram and for revascularization. If a stress test is intermediate or low risk, then we advise them on optic treatment. So we can perform them a stress test. In a stress test, we have multiple options that I'll be discussing after this slide. Then who are the candidate for the stress test? Patient with the unknown coronary artery disease and the anginal symptom of CCS 1 or 2. In 3 and 4, we perform the angiogram. We intervene them for obstructive coronary artery disease. In angina symptoms 1 and 2, we can perform the stress test to risk stratify. Asymptomatic intermediate risk on risk about vigorous exercise or the high risk occupation. If a patient is a pilot or a train driver or a bus driver, and he has a multiple risk factors, but he's clinically asymptomatic, so before starting his job, we can perform his stress test, and if a stress test is a high risk, we will intervene him and we will stop him the working till his coronary artery disease is treated. And if a stress test is a normal or the negative or the low risk, can proceed with this work. So with the high risk job, we can perform this stress test. And these are the indication. People with the unknown coronary artery disease. With the known coronary artery disease, the patient had MI, is a past history of the MI, now clinically asymptomatic, we can perform the stress test to risk stratify. Pre-operative risk assessment, we can perform the stress test, and recurrent angina, despite of optimal medical treatment or the revascularization, we can perform the stress test to risk stratify the how much patient can walk or can exercise. Stress tests are not performed in acute MI within the 2 days. If a patient had a MI, recent MI, we will not perform. Definitely, stress test will lead to the increased mortality. Unstable angina, definitely patient has a rest pan. We cannot perform the stress test. Cardiac arrhythmias, patient has atrial fibrillation, ventricular tachycardia, or supraventricular tachycardia. We cannot perform the stress test in these dysarrhythmias. Aortic stenosis is a severe. Stress test is contraindicated. Decompensated heart failure, stress test is contraindicated. Pulmonary embolism, myocarditis, pericarditis, or aortic dissection, stress test is contraindicated in these conditions. These are the list of the stress tests that we can perform with respective sensitivity and the specificity. On top is a CT angiogram or the stress echocardiography. In common our practice, we perform stress echocardiography. MPI, myocardial performing index, and we common term is used is a thallium scan is also used in our practice. PET scan can be performed as a stress test. MRI can be performed, cardiac MRI, and exercise ECG is commonly performed in our practice again, which is called ETT, exercise tolerance test, is the exercise electrocardiogram. If a patient is a high risk, on stress testing, we will proceed for the intervention, coronary angiogram and the revascularization with the coronary angioplasty or bypass grafting. So these are the high risk features on the test we have discussed. If a patient has a LVEF less than 35%, then we have to intervene further. Resting perfusion abnormalities. Suppose if a patient has a stress echocardiography, 10% myocardium is involved, or on thallium scan or PET scan or MRI, there is a 10% of myocardium is involved with ischemia on the stress, again patient is a high risk. ECG findings, if a patient start walking on the treadmill on the exercise ECG test or the ETT, and patient develop the more than 2 millimeter ST depressions, then patient again is in high risk. So these are the high risk criteria for the non-invasive test. So these all are the non-invasive. Invasive test is the coronary angiogram. So here is another scenario. Dobutamine stress echo. Dobutamine is a drug which increases the heart rate and the blood pressure, and we perform the echocardiography during the infusion of the dobutamine, and we see the wall motion abnormality and the changes. He has angina pectoris and sweating and the hypertension, and ECG shows the ST elevation in the 3 AVF, ST segment depression, and 1 AVL, and hypokinetic inferior, middle, and the lateral wall. What you will do for him now and the what class? Okay, so this man developed the chest pain and he become hypotensive and he developed the ECG changes. So this man, when performed the stress test, become hypotensive, developed ECG ST elevations, and developed the chest pain. So he has a significant coronary artery disease, probably in his left circumflex or the right coronary artery. So next step will be the coronary angiogram. So in this patient, we will perform the coronary angiogram. Coronary angiogram, major coronary artery is a significant stenosis, is a more than 70%. And if we treat it, and the treated coronary artery disease is a more than 50%. So indication of intervention, indication of the coronary stenting or the bypass grafting starts with the 70% stenosis in the main in the left anterior descending left circumflex or right coronary artery, and the more than 50% in the left main trunk is called as a significant obstructive coronary artery disease. So advantages of the coronary angiogram: to assess the patient's risk of the death and the future cardiovascular event, to ascertain the feasibility of percutaneous and the surgical revascularization or the medical therapy. So in stable ischemic heart disease, when to perform the coronary angiogram? If a patient is a high risk, we have to perform the coronary angiogram. If a patient is a low or intermediate risk, we will keep them on the medical treatment. In the guideline directed medical treatment, coronary artery disease revascularization, which include coronary artery bypass grafting or percutaneous interventions, is the coronary stenting and the follow-up with the patient with a stable ischemic heart disease. And medical treatment, reduce, what are the objectives? Reduce the premature cardiovascular death, prevent the complication of the stable ischemic heart disease, non-fatal MI and the heart failure, maintain or the restore the activity of the patient, and minimize the cost by eliminating the avoidable adverse effect of the test and the treatment, by preventing hospital admission and eliminating unnecessary tests and the treatments. How will we educate these patients? The importance of the medical adherence for the managing of the symptoms and retarding the disease progression. We will counsel them. They have to adhere to the medical treatment and the comprehensive review of the all therapeutic options, an appropriate level of exercise, encouragement to maintain the physical activity, and introduction of the self-monitoring skills. Information on how to recognize worsening cardiovascular symptoms and take appropriate action. Lifestyle changes: stop smoking, start walking, and stop junk foods, and control blood pressure, control type 2 diabetes, and uh, also avoid to secondhand smoke. So these are the counseling factors that we have to counsel our patient, that he has to be very compliant to the medical treatment. So we start with the antiplatelet therapy. If a patient with a stable ischemic heart disease, we start with the aspirin 75 to 162 milligram and should be continued indefinitely. Lifelong treatment with the aspirin. If a patient is allergic to the aspirin or not tolerating aspirin, we can add the antiplatelet drug, that is a clopidogrel. Clopidogrel is the alternate to the aspirin if a patient is not tolerating aspirin. And we add clopidogrel with aspirin. It means dual antiplatelet therapy if a patient with ACS or patient has had coronary intervention with the coronary stenting. He has to take up to the 1 year dual antiplatelet with the aspirin with the clopidogrel. And with a single aspirin only is used if a patient is a stable ischemic heart disease. Basically, we inhibit the platelet function by starting the aspirin, so that platelet function is reduced and the chance of thrombus formation are also reduced. So it prevents the future events and reduce the future cardiac events. And other options, we have a beta blocker therapy. And beta blocker, as I have already told you, there is a demand and supply mechanism. If a patient has a high heart rate, he needs more blood supply to the myocardium. If a patient has an obstructive coronary artery disease, if patient's heart rate is increased, demand is increased, he becomes symptomatic. So we start with the beta blockers. Beta blocker reduce the heart rate, reduce the demand, and the supply which is going on will be sufficient with the beta blocker therapy. So beta blocker reduce the heart rate and they reduce the demand. Renin, angiotensin, aldosterone blockers. These are the basically antihypertensive drugs and the vasodilators. And these are indicated in the patient with the coronary artery disease with the LV function down less than 35% or patient is an hypertensive. So we start with the AC inhibitor. With a number of drugs with the AC inhibitors. We can start with a single drug if is LVEF less than 35 or the 40%. If a patient is not tolerant to the AC inhibitor, the alternate is the ARB, angiotensinogen receptor blocker. Angiotensinogen receptor blocker is non-inferior to the AC inhibitor. We can consider as an alternate to the ACE inhibitor. We cannot start both drugs at same time. There is a chance of renal failure. So you have to select single drug, ACE inhibitor or ARB. If a drug of choice is a ACE inhibitor, the data shows more benefits on the ACE inhibitor, but ARBs are the non-inferior. Influenza vaccine, patient has to take influenza vaccine every year before winters, so that it will be prevented from the infection and recurrent heart failure. It is also indicated in the patient with the. We have an option as a calcium channel.
Recording in progress.
Relieve. We have options of ranolazine. Ranolazine is a newer anti-anginal which can be used in a patient with a stable angina or the patient to whom we cannot perform the revascularization. Coronary angioplasty, stenting is not possible. Coronary bypass is not possible. Patient has a significant coronary disease. We can add on this newer anti-anginal to relieve from the symptoms. Nicorandil, again, a newer anti-anginal. We can start with the nicorandil. We can add on the nicorandil. Ivabradine is a rate controlling agent, and it has the same function as of the beta blocker and the calcium channel blocker, but has a mechanism of action is different than the beta blockers and the calcium channel blockers. Mechanism of action of the ivabradine is a funny channel blockers that directly act on the sinus node and reduce the heart rate. This is basically rate controlling agent. If we decrease the heart rate, decrease the demand, and we can alleviate the symptoms. Trimetazidine, again, as a newer anti-anginal drugs, we can add on with the other medical treatment of a patient to whom revascularization is not possible. Trimetazidine, again, we can add on. Blood pressure should be controlled, diabetes should be managed, and revascularization if needed with the coronary artery bypass grafting or the percutaneous interventions is a coronary stenting if possible. So these are the different slides for stable coronary artery disease. And one important drug that we forgot to mention is statins. Statins are the HMG-CoA reductase inhibitors, and also class 1 are indicated in the patient with all patients with the coronary artery disease. Rosuvastatin, atorvastatin, simvastatin, pravastatins are indicated in the patient with the coronary artery disease. You have to start, and he has to take for the lifelong statins. Even if the cholesterol is normal, it has an action on the stable atherosclerotic plaque. So patient has needs lifelong follow-up with the cardiology clinic, initially weekly, then monthly, then 6 months, has to follow the cardiology clinic. So this is all about stable ischemic heart disease and its treatment and the management. Thank you so much.